So in the interest of time, we're going to go ahead and roll right into our first panel on mobile health, one of the most sort of interesting innovations that's happening across the healthcare system right now. As we put more watches and Fitbits and trackers and apps and everything into patients' hands, and others, and physicians' hands and others. So with that, let me introduce Raymond Charles with the National Library of Medicine, and a late addition for his slides. I'm going to give him a hard time. Yeah. So this is our research panel. Take it away, Raymond.
Morning, everyone. I'm Raymond. I'm the first speaker and the moderator for the mobile health panel. Wow, the light's not really going so well for my slide, but I'll try to wing it. So this presentation is titled A Retrospective Review of the State and Trends of PDAs, Smartphones, and Tablets in U.S. Hospitals. So to begin, I want to show you guys the consumer market. This is published from ComScore 2015. And one of the things that I want you to look at here is that starting in the 2005, HP, Palm, and Symbian are the market, the big market holders for smartphone devices in the consumer market. These are patient-facing devices, and I bet everyone here who had a smartphone during this time can attest to the fact that during 2005, you had a Nokia, a Palm, or some form of, there were no iPhones and Android phones during this time. And then after a span of about a decade, approaching 2015, we see a 90% market share for iOS and Android devices, and that's not such a big surprise, seeing as probably in this room right now, I saw a lot of people using iPhones and probably some version or iteration of an Android device. Unfortunately, what led to the demise of the Palm, HP and Palm was that during the 90s, most physicians that I know had some form of Palm device, a Palm Trio, Life Drive, or a TX series, with all these Symbian-based health applications on their PDAs, their Palm PDAs. But Palm was acquired by HP in 2010, and then previously in 2009, HP developed the operating system WebOS, which maybe a lot of people here are not familiar with because it failed. Not really failed, but it was when HP acquired Palm in 2010 and 2011, HP dropped out of the smartphone scene and released WebOS as an open source platform. So that probably might have led might have been because of their market share. Symbian, of course, by Nokia, they shifted from a Symbian operating system to Windows Mobile OS. But Nokia peaked at around 2007, but in 2011, it's about 5%. Looking at BlackBerry, or what was previously known as RIM, or Research in Motion, it had a big market share during 2009, where it had 41% market share, but seeing as in 2012, it dropped down to 6.4%. And what I want you to note here in the slide is that, again, this is the consumer market. This is you guys. These are the physicians. These are the patients. And these are just everyone. Sadly, a lot of developers use this information to benchmark or create mobile health apps, or to create apps to interface with their EMR or EHR or HIT systems. Unfortunately, that's not what we see in the data. Well, it doesn't look like it's focused, but I'll try to wing it also. Our source of information is, of course, from the HIMSS Analytics database. Thankfully, we have someone from HIMSS North America here. Just a small background on the HIMSS Analytics database. A lot of presenters yesterday used the HIMSS Analytics database. In '86, started as the DARNFest 3000 plus database. And in '98, it got merged with the DARNFest IHDS Plus, or the Integrated Health Delivery System database. In 2004, it was acquired by HIMSS Analytics. And thankfully, last year in July, HIMSS Analytics released their database for free to researchers. That's why I think a lot of us used it. So that's good. Hopefully they do that again this year, next year, and for years to come. So that's our source of information. Sadly, HIMSS North America did not publish this information, so we thought of looking at that for the sake of mobile health. So what does this slide show us? We saw that BlackBerry or RAM is actually the leading smartphone or PDA device that is being used in the hospital by either physicians or the people working there. And this may be because BlackBerry or RAM markets themselves as a very secure platform. Most physicians communicate to each other using email, and using a BlackBerry device, they can use the BES or the BlackBerry Enterprise Server to send their, secure emails that's HIPAA accredited or, for patient privacy. So that's the increasing trend you see in the third column. Sadly, on the rightmost column, I think that's HP and Palm devices are steadily decreasing, but not as extravagant as what you saw in the previous slide. That's because probably perhaps legacy systems in the HIT of hospitals have tightly integrated with these operating systems before. What you can see also on the leftmost side of the first graph on the top left is Apple. And we saw that since its introduction in 2009, that uptake for it is increasing, but is in fact slow. But we need more data because it's already 2015, and this is only up till 2012. 2012 data can be seen in the lower left. We saw that on the leftmost hand side, that's Apple. BlackBerry is the highest PDA being used in 2012. Second, I think it's still HP. Third is, I think that is iOS or Apple devices. The blue column is current use, and the red bar is projected use, or hospitals planning to use or integrate these phones or accredit these phones for hospitals. Secondly, we looked at convertible tablets and slate tablets and aggregated them together. So I guess the take home here is who knew what motion computing was? So there. So if you want to, so I guess the bottom line is these three things. Consumer, you shouldn't look at the consumer market to target the mobile health applications in the hospital. And these information can be useful for addressing hospital stakeholders and whatnot. Thanks. So introducing our next speaker is Dr. Thomas Martin from the HIMSS North America. So while they're looking at the slides, Dr. Thomas Martin is the director with HIMSS, a global cost-based nonprofit organization focused on better health through information technology, with 10 years of experience in healthcare. Dr. Martin joined HIMSS from the telecommunications and health IT industries. He's lived overseas in Australia and all around the Asia-Pacific area. He started his journey in healthcare working at the Cleveland Clinic Foundation and served as project lead for numerous health IT implementations and mobile app development. And he has authored numerous articles and book chapters on the role of mobile health and the use of cost-benefit analysis in healthcare. He completed his dissertation titled Applications of Contingent Valuation and Conjoint Analysis in Mobile Health, and Understanding the Willingness to Pay for Healthcare Smartphone Applications at the University of Delaware, and has a master's degree in business administration from the same university in Delaware.
It's a really interesting time right now in healthcare, and a lot of you are, how many health economists do we have in the room? I love to do participatory stuff. A couple, a handful. Okay. You're probably saying, why am I worried about mobile applications? Why am I worried about real-time analysis? I think what's going to happen over time is that we're going to have an opportunity to collect both physiological information around patients and a lot of information around their social economic status, the social determinants of their health, right? And we've done a lot of that through retrospective analysis, but now we have this amazing opportunity to do this in real time and to look at, take a really in-depth look at what the patient is doing. So Back in March of this year, Apple introduced ResearchKit, which is a platform that allows for a couple of different things for researchers to embrace. And I think it's really important to highlight to folks that this is not just a plug-and-play type of application, but as you're maybe working with fellow researchers to think about how you can bring developers into the mix to leverage this platform a little bit more. One of the things that I do want to highlight in terms of the opportunity for this, which is really revolutionary, is the ability to reach out to a lot of the consumers to participate in these types of research applications. So to date, the largest Parkinson's research trial had 1,700 participants. Within about a few hours of uploading a research app to Apple's iOS, they had over 640 downloads in 3 hours. So that doesn't always mean that you have the right population in front of you, but I think it highlights the tremendous opportunity to engage with individuals around their health and to extract information from them. So what are we doing? We're really looking at patients as they transition from home to hospital back to home again. And I think there's touch points for us to consider research efforts around any one of these use cases. And I think one of the opportunities that's coming online is the ability to recruit folks at a point of service, right? So through mobile applications, through low energy Bluetooth settings, through iBeacons, we can start to prompt individuals who have an app already loaded for a hospital or health system to maybe think about enrolling in a clinical trial. So what are some of the capabilities that we have right now? Right now, we're really looking at, again, aggregating some of the physiological and social determinants of folks' health. So we can aggregate that information through two big platforms that Apple has released. HealthKit, which has about 60 discrete elements related to health right now, and ResearchKit, which is more the layer on top of this to do things like surveys, to do things like cognitive tasks. I'm going to talk just briefly about HealthKit and the 60 discrete elements. I think it's really important to note that those are determined by Apple, so we might not always be able to engage in the types of research activities that we want to. So if you wanted patients to self-report Chem7 panels, which is a really kind of standard laboratory test that's being done, that's not necessarily what Apple's trying to do. So again, this is a little bit more focused on consumer health and wellness types of reported measures. And again, we're going to do a little deeper dive into ResearchKit. There's 4 key areas within ResearchKit that they're taking a look at. Motor activity, so your gait, pedometer, steps walked, things of that nature. General fitness, cognitive efforts, so if you are a patient who is maybe undergoing a pharmaceutical drug delivery, can you remember specific tasks, right? And then voice recognition and feedback. Some of the key things that I want to highlight is that a lot of this does require you to program in Objective-C. So again, if you're out there thinking about how do I leverage this platform for research going forward, you really need to think about budgeting for developers because you'll basically be building this application from the ground up. It's very flexible in terms of the questions that you can ask and prompt people, but again, it sort of requires you to have an understanding of programming languages to really develop and put it in place. One of the other things that I want to highlight for those of you who might sit on IRBs or who are undergoing IRB approval for something like this, there are some guidelines out there around digital consent. One of the other key features of ResearchKit is the ability for a patient to sign and attest or give their consent for participation in a research study. For those of you who maybe have an IRB that's saying, listen, you got to have a paper form, the Office of Human Research Protections does have a lot of guidelines around the use of digital signatures. So there's a couple of things that they highlight in terms of key guidelines that you need to think about. So first, how is that signature created? The legitimacy of that signature. So I think it's important as you're building your workflows or thinking about how you stand up a research effort using some of these platforms in digital technology to think about how do you verify the individual that's in front of you? How do you maybe ensure that they're not just going out to an app store, downloading your app and leveraging it for research purposes. So I think that's an important step that you really need to think about. If you're having trouble with your IRB, I think it's really important for you to think about engaging other individuals throughout your organizations who might be more well-versed in computer science or have an opportunity to really walk you through the nuances of HIPAA requirements for transporting a lot of this information. One of the things you're not going to get Apple to do is sign a business associate agreement. So if your IRB comes back and says, we want Apple to sign a business associate agreement, it's not going to happen. So I think it's important to really think about how you can leverage some of the other folks on your team. Finally, I highlighted some of the marketing and research opportunities, the use of iBeacons. I think the ability to recruit a lot of these patients is profound into studies. There's definitely the ability to leverage iBeacons, a lot of the notifications, right? I think as news breaks, we all see it come up. So I think it's important to think about how we can really leverage those types of technologies to recruit patients a little bit better. Lastly, some key takeaways. So HealthKit, the elements they have are hard-coded by Apple. If you want to research something that's not in there, it's going to be quite difficult. ResearchKit, it's not necessarily a plug-and-play type of environment. You're going to need to have developer support. You're going to need to have funding for the build-out of the mobile application. IRB considerations, I think, and precision medicine, as we move forward on this, it's going to be really important to ensure that you have a leave-behind offering for your patient so that as your patient participates in your research study, that they have ways to extract and use their data and move it around the ecosystem, because it's going to become increasingly important as precision medicine becomes the bigger buzzword of the day. I think today is probably the day that we can call big data dead and precision medicine the new big buzzword. So with that, I will say thank you and continue on.
Our next speaker is Keara McKenna Diamond. She graduated with a BA in Economics and Political Science from Chatham University. She also finished a Master's in Science in Healthcare Policy and Management from Carnegie Mellon University. She's a healthcare domain specialist and international strategy analyst from MITRE Corporation.
Thank you, Raymond. And thank you all so much for being here with us on a Saturday. I have the pleasure of representing the MITRE Corporation and my research partner, Christina Sheridan. Christina and I have had a chance to work on this research together for the last 3.5 years, actually developing an app called the Patient Toolkit. And the Patient Toolkit is unique in the market because it collects symptom data from individual patients, symptom severity data, medication adherence. It reminds patients about upcoming doctor's appointments, and it tracks all of this longitudinally. And so for Christina and I, this really comes from a place of wanting to better engage patients and empower patients. And through that work, we've really started to ask some deeper questions about why is patient engagement not delivering a lot of the results that we've expected it to date. So just to quickly level set, there are a number of definitions about what patient engagement and patient empowerment really are. There's a definition by Kristen Hardman et al. Published in Health Affairs in 2013 that we really enjoy. We've made our own slight modification to it, but the concept is generally that patients, families, the representatives, and health professionals work in an active partnership across the healthcare setting. Our addition is also that they work in partnership in the home to improve health and healthcare. And why is this important? Well, at the heart of it is really trying to improve communication between patients and their providers. We see as a result of this, in many different studies, the opportunity for decreased costs as a result of decreased utilization. We see an opportunity to improve the quality of care. And we also see an opportunity to actually improve the efficiency of care. And so there's a lot of great benefits that we think can come from this. And so after we sort of did a deeper dive into the literature, as well as our own work in sort of the concept to launch process of developing this app, we started to really ask ourselves, why is this not being implemented more fully to date? And so when we looked at the literature, looked at the environment, we sort of came to this working hypothesis, which is that the ways that patients are trying to be engaged are being done in these 3 key silos. So we're trying to better communicate with patients, we're trying to engage them through technology, and we're trying to engage them to live healthier lives by incentivizing them to do so. And all 3 of these are supported through 2 different payment mechanisms generally, whether it's through fee-for-service or clinical quality measures. We see there's no incentive or no way to really pool these 3 silos together and in general effectively implement them. So what we propose is that in a future state, which we hope is not too far off, that these 3 silos could actually come together and then be supported by policy to more fully realize the benefits of patient engagement and empowerment. So for us at MITRE, it's really important to not just think about sort of in theory how this could work, but in practice how it could work. So I realize that you cannot read this chart. I have a blown up version, don't worry, to sort of walk you through. But what we wanted to do is really look at the brass tacks of how can we use communication and technology for patients and providers throughout the care continuum to really engage patients more fully. So as an example, let's take the first consultation between a patient and a provider. There's some key aspects to the use of communication and technology in that first encounter that we would want to see happen. So as an example, for the patient, we would want the patient to be able to articulate their current and past experience with their health condition and advocate for the desired target health and wellness goals. Similarly, we would want a provider to explain the clinical aspects of their condition to a patient and solicit clinical information. And so this is an example of what we would want to see done. This is, of course, going to vary by patient, provider, what's happening with the patient population that we see. But we wanted to provide this in our paper just as a way to help make it more real, make it more tangible for people. And in order to sort of bring together these three silos that we see supported by policy, we've then gone through that care continuum and the behaviors we want to see, and we've given examples of ways that those behaviors can then be incentivized. So again, it's about how do we take the theory and make it practical. And I am coming up on time, so I will quickly move to our recommendations. So in general, in terms of fee for service, we would really like to see the concept of patient engagement incorporated into clinical quality measures. We are not advocating that more clinical quality measures be developed. We are advocating that this theory, these ideas, the essence of this really be brought into clinical quality measures. As well, we would encourage CMS to create a relative value unit for patient engagement. It's something we've heard repeatedly from providers that they would like to see. As value-based purchasing quality measures are developed, again, just bringing these concepts into the fold. And we encourage insurers, public health officials, and policymakers to work collaboratively at a state and local level to determine how these incentives should be designed to work well with that population. And with that, I am out of time. Thank you.
The next speaker is Dr. Idris Adjerid. He finished a MBA in Business Information Technology from Virginia Polytechnic Institute and State University, a PhD in Information Sciences from Carnegie Mellon University. He worked as a senior IT analyst in the Government Accountability Office and is currently an assistant professor in Information Systems at the University of Notre Dame Mendoza College of Business.
Okay, so good morning. My paper kind of focuses on the potential of, or actually our paper, so this is joint work with Corey Angst, Ralph Gross, and R. Coulter. And we're focusing primarily on this question of whether mobile technologies can kind of be part of, or one of the keys of unlocking IT value, but really on the supply side, right? So a lot of the mobile discussions in healthcare have been around, can we engage patients better? Some of the work has been around technology acceptance. But this is actually kind of an application that we look at that's saying, can we help some of the supply side issues or operational issues for hospitals by using mobile technologies? And I probably don't have to argue too much that mobile is a pretty natural fit for healthcare, just kind of due to the fact that healthcare tends to be a very hectic context, a very busy context, in which case technologies that you can carry around that are quite powerful, tend to be quite valuable. One of the other things that kind of useful to think about is that these mobile technologies, even though they can be kind of lightweight and flexible, they can still be quite powerful. When you introduce things like cloud computing, you can incorporate things like analytics. For those of you who were in the session yesterday, we talked a little bit about some of the analytics capabilities, but that's actually, in some sense, just another feature of this tool that I'll be talking about here in a minute. And the final piece is that you can think about mobile technologies as being integrated with the existing infrastructure as a way to address targeted issues, as a way to customize technology for a specific care context or hospital. Okay. So we actually focus on this problem within healthcare of patient handoffs, which refers to this kind of phenomena of it being quite difficult to transition patients from one provider to another. In fact, some studies find something, as high as 70% of adverse events are actually at least partially a function of poor patient handoffs, right? This transition between providers, nurses, and physicians in healthcare contexts. Right, so we're looking at this this application called BlueView app. And effectively what it does is it takes this reasonably ad hoc process of looking for an inpatient admission. So somebody comes into the emergency department, they're cared for, they're triaged, all these things, right? And then there's a decision that's made about whether we admit that patient to an inpatient unit or not. And that process tends to be fairly ad hoc, even when a hospital is adopting EMR and EHR and all these different kinds of things. So this app is actually an iOS app, right? So it runs on any Apple device. And what it does is it facilitates and it standardizes this process of communicating a request to an inpatient unit and getting that process kind of standardized and getting it electronically. Okay, so it has 4 stages. So initially, once the provider in the ED or the emergency department thinks that a patient is to be admitted, they send a soft request to the unit, which replies back with a soft approval. And then once they're more certain that the patient will in fact be admitted, they send a hard request and a hard approval. And all of this is facilitated through this app, right? And it's used basically on any iOS device. Okay, so we actually start to evaluate the value of these kind of apps in practice. This is actually implemented in a Pittsburgh hospital. And we look at data from 54 months, includes data on 145,000 patients and close to 60,000 unique patients. So some of those are repeated. And we do kind of an analysis that we've seen several times throughout White, so I won't have to explain it too much, but it's a fixed effects analysis. You have time trends and unit fixed effects and patient fixed effects. And we have a number of controls around the ED and other things, and we look at basically what is the effect of being admitted on the length of stay, right? Does it increase, decrease your length of stay? And how is that effect moderated when you use this tool, right? So over this time period, about 1.5 years in, the tool was implemented in the hospital, okay? And what we find is some pretty meaningful value here. So the first thing we find is that actually an admission extends the length of stay in the ED by between 2 to 5%, depending on the specification and the controls and things like that. But we also find actually that when you use the app, when the app was introduced, almost a 3 to 7% decrease in the length of stay. So facilitating this handoff between the providers actually resulted in patients that are admitted being in the ED even shorter or less time than those that were discharged, right? So one of the things that I'll note is, part of the limitation of this is, the integration between the app and the existing EMR platform could still be a challenge, right? So it kind of sits somewhat on top of the EMR, but is not purely integrated, and it's primarily, so there's some competitive reasons and other reasons why that's quite difficult, right? But we see that, potentially these third-party mobile applications could be quite valuable in thinking about health IT value and unlocking some of these benefits in a targeted, more lightweight, more customizable technology. Thank you.
The final speaker is John Calhoun. He finished a master's of Science in Health Informatics from the University of Texas School of Biomedical Informatics in 2014, and is currently a project consultant in the Institute for Cancer Care Innovation in the same University of Texas MD Anderson Cancer Center.
So we were really intrigued actually with one of the special interest areas that was scheduled for the conference here, and that was with regards to incentivizing behavior change. And so at MD Anderson, one of the things that we're focusing on is value. So we generated a paper essentially to kind of look at value, and when you talk about value, really, you have to give it a definition, and the definition that we look at is really kind of outcomes over cost. Okay, and what we found is we decided we'd do a systematic review, essentially, and look at papers that talked about use of technology in healthcare, essentially, and what we found was less than 1% of the papers that we looked at that talked about cancer care delivery and use of technologies, less than 1% of them actually included a discussion of costs. So when you talk of value, and we're here at the business school, we really have to consider both outcomes and costs. Okay, and so I'm not going to talk the bullet specifically, but one of the things that we need to make sure that we begin doing then is having an open conversation about costs. So how do we begin to get people to openly talk about costs with regards to healthcare? If you don't, as the third bullet there says, it's really challenging to make policy or value decisions if you can't do a comparative assessment. I already mentioned bullet 4, which is value, as I want you to remember this, is outcomes over cost. And you'll see that from a patient perspective, I put best there because anytime you talk value, it's a comparative kind of an assessment. So how do you actually do that? And then per the last one is you really can't assess value in the absence of either one of those. Now, just to go back a little bit, so when you think about healthcare and you think about cost, traditionally in this country, if you go read the papers over the last 20 years, you will see that, culturally, we're opposed to actually talking about cost with regards to healthcare. Americans really are kind of resigned to say, hey, we don't like limits. And because of that, we don't typically tend to want to focus on cost in healthcare. It's pretty much well summarized in one specific paper on cost effectiveness analysis that I found from 2004 by a guy that if you recognize his name, he's done quite a few papers on cost effectiveness analysis and so forth. It's Peter J. Newman. And I won't read the quote there, but it pretty much characterizes our view kind of nationally of cost in healthcare. Okay, so before I go to the next slide then, one of the things that we wanted to focus on then is how do we begin to comfortably engage people in open discussion about cost. And so our goal then was to kind of find an area where we felt that perhaps the access to care or the appropriation of care or even the research that we all tend to like to do wouldn't be threatened by a cost discussion. So how do we do that? So part of the conception there, or misconception, is that when we're talking about cost, it's across the entire healthcare spectrum, and that's not necessarily true. When you go look at specific sectors, if I go and I look at, say, administrative or processes associated with the delivery of care, it might actually be okay for people to really then think about it, because we're not talking about denying access to care. We're not suggesting that you go and then say, hey, let's minimize research or anything like that. But, technically most people in the country, we think, would still like to get the best cancer care that you could possibly get. But if we could actually reduce the administrative burden by 50 to 80%, who would not go for that? Okay, so if I can reduce the paperwork and all the other things that you have to do by a significant amount, why would you not go for that? And that's what the third bullet really means. It doesn't imply that there's a concern about cost considerations in the context of administrative processes. And it would really be no different than the things like about are happening these days with meaningful use, electronic payments and so forth that are decreasing at least the administrative burden of administering healthcare by $4 to $10 billion. So same things that we really want to do in the mobile technology area. I mentioned bullet number 4. And then essentially then enter mobile technologies. It seems like it's a prime opportunity then to have an open discussion about costs in areas where we're not impacting access, we're not trying to delay people's desire to do research. So it seems perfect for administrative burden. And my quick example, because I'm running out of time, is if you go back and look at I think this was actually published in 2012, but it was data from 2009, where the IOM actually did a report. And in it, it talks about $750 billion. So I'm imagining that most people in this room have heard that number before. But in that 750, when you look at the categories, I've listed a few there, but probably 90% of the categories were associated with administrative reasons, not really anything else. So it's a prime opportunity then to use mobile devices. And then I'm going to skip to the last one because I'm out of time. But the recommendation then is I really think when we talk about incentivizing behavior that we actually have to do that. So you have to create incentives for people to talk about costs. And one of the ways that we think to do that gracefully is to then require journals to require a cost effectiveness analysis, a cost utilization analysis. We can eventually agree on which one to use, but we have to start including that in our discussion. So that's our recommendation. Thank you.
So we have been trying to actually include cost and quality trades in healthcare. And the great difficulty is that with the providers, we actually get what's called end-to-end cost and not individual process costs. So if you don't get individual process costs, you cannot actually even understand the causes of cost. That is even in the healthcare delivery itself. But the problem you raise is the real one. We know from evidence, as you know very well, that 40%, that's where this number comes, of the annual cost of medicine in the US comes from completely, wasteful administrative expenses. So the question is this. Mobile devices is one way to actually facilitate the process. as long as they are well integrated with the management systems of the hospitals. That has not happened. You see any way that this can be facilitated? And in that question is related what I call the state and other offices can actually have the power to create uniform processing of costs, right? Which doesn't exist in this country. It exists in Germany and Israel, and takes some of this overhead away, but then you require to have the mobile devices and the fixed devices and the health management integrated. Do we see any light in this direction?
Well, that's a really tough question. To be honest, I don't really have a good answer. I would just suggest, as we're talking about in this paper, that we have to at least start small. So even though we're probably not going to get an end-to-end cost anytime soon, because as you know, the payment system, people don't actually understand what a healthcare episode actually costs today, nowhere in the country. So it's very challenging. So at a minimum, what we'd like to do when we start talking at least about mobile devices is to say within a given institution, take MD Anderson for instance, I work with physicians that want to implement mobile devices, things in RedCap, where you have a function called Twizzle, I think, that text messages patients and so forth. And typically what happens is the loudest person that comes along, we tend to pick their technology solution and go with it when no impact assessment has been done. So my take would be to start small and say within a given clinical flow, maybe just one process at least, then to begin to get people to think about the cost. If you try to take the big piece, the big chunk end to end, you're just going to probably lose people along the way. So I think our best hope is to start small with individual processes and get people in the habit of thinking about a cost effectiveness analysis or business impact assessment, whatever floats your boat.
Okay.
Hi, this question is for Idris. Thanks for your talk. The app sounds interesting. I'll check it out. A comment and a question. For us emergency physicians, prolonged length of stay in the ED has been a chronic problem. It has been for years. Not only does it negatively affect provider and patient satisfaction, there is also a financial bottom line. If the LOS is really high, then we have patients leave without being seen. And these are patients who have already come to us for care. They're in the building and they leave because the LOS is not efficient. And there is data, at least until 2012, that emergency department visits are actually on the rise, despite the nationwide push towards reducing ED care. So I think there's a lot of value for this app. My question is, can you share us any sub-analysis? Have you looked at cohorts based on chief complaint or diagnosis, or time of day or days of week, where the app may be more effective?
Yeah, so that's a good question. So we've looked at a little bit by the kind of patients that come in. And honestly, this is kind of reasonably early analysis, so I don't want to speak too conclusively on any kind of trends. But one of the things that's interesting is that the controls in our analysis are all quite significant. And one of the things that we've seen is that there's seems like a reasonably robust interaction with how crowded the ED is and the effectiveness of the app, right? So in the sense that it seems like it's generating a disproportionate value when the ED is particularly crowded, which kind of lends credence to this idea that the mobile nature of the tool is really what's driving some of the benefits and kind of allowing nurses to kind of balance some of these pressures a little bit better in the ED or providers just more generally. But that's definitely the path that we're heading down, is trying to figure out where is this value most pronounced. Actually, one of the other things too is that we have reasonably good use logs data, so we know when they sent the request, when it was sent back. And one of the things that is particularly problematic in terms of length of stay is when a provider actually makes a request to the wrong inpatient unit. So, they make a request to one inpatient unit, ultimately it gets rejected, they have to remake a request, and that can be, you're talking about 20-30% increases in the length of stay when that kind of a mistake happens. So there are some, I think, points that we can look at in terms of when the tool could be most valuable.
One other related question, is this a learning system? When Ralph mentioned yesterday that it's inaccurate 15% of the time, does it take into account where it could actually, placing a admit request may increase the length of stay? Does it take that into account as the system progresses?
I don't, Ralph can correct me, but I don't think there's been a lot of thought yet on implementing kind of analytics in that part of it in terms of, kind of ex post analysis on where did the length of stay get bumped up versus not. In some sense, this is kind of the first phase of that.
Thanks.
Couple of questions. One for Keara. The app that you mentioned that you developed at MITRE, I wasn't sure exactly, in terms of for patient engagement, is that something that you've released publicly and available for research? Some background on that. Second question for Idris actually is, in your model, you've modeled length of stay as the dependent variable. And I presume admission is once they've been admitted, not in the ED, but as an inpatient, correct?
That's right.
As an inpatient.
That's right.
The question I had for you was, why, once they're already admitted as an inpatient, the problem is, I think the more interesting question is, what is the probability of being admitted once they're in the ED? Because that way you can take some preventive action in the ED before the patient gets into the hospital. I was maybe you have a better thought process for explaining why you did what you did in your model, but I was trying to come at it from the point of once the patient is in the ED, before they get to the hospital, what types of preventive actions you can take. So just a couple of different questions in that space.
Great. Well, thank you for the question. I'm glad to have my research partner, Christina, here with me because she manages a lot more of the tech transition aspects of it. So, Christina, if I say anything wrong, please jump in and correct me. So just a quick word about MITRE. We are a privately held not-for-profit company, and so we operate what are called federally funded research and development centers, so like the RAND Corporation. So we don't develop commercial products. That said, we are looking to pilot it in different environments. And if that was the case, if it was a pilot directly with the government, we would just transition the technology, the prototype in its fully functioning form to the government. Or we could, for a small fee, do a commercial license to a not-for-profit, let's say, to pilot it in an environment. And so those are sort of the two best options available. There are a couple of little bugs in the app right now that are being worked out, but it is fully functioning. And we've done feasibility studies with the University of Virginia with multiple sclerosis patients to date. Does that fully answer your question?
And is this a mobile app or something that you do it on a computer?
Actually, it's developed in both. So we do have a web portal that works, which is what we use with multiple sclerosis patients, but it's also a fully functioning iPad app. Yeah, sure.
Okay, so that was a great question, actually, and I mean, I just make sure I understood you correctly. So you're thinking about this idea of instead of figuring out how to ease this transition, is preempt the admission effectively, right? And think about how to do that. So I think in some sense that's kind of part one of some of this. I mean, part of the analytics ideas around some of this tool is trying to predict the admission really early on, and from that point, kind of decide what to do, whether it be facilitate the admission procedure. Actually, to be honest, we hadn't thought about an intervention where you tried to prevent the admission, which is a really interesting idea. One of the other things that could be really interesting is, we talked about interoperability as a challenge, right? So so there's been some challenges in terms of getting the tool integrated fully with the EMR system. What would be, also immensely interesting is thinking about, as soon as the patient gets in, you have this detailed history of not only of their previous ED visits or whatever else, but you could make that prediction pretty early on and think about maybe a lot of different ways of using that prediction as long as you get it kind of good enough for it to create value. So it's definitely in our thought model, but this is more along the lines of an operational kind of perspective. How do we make this process more efficient? And there's profit motives, obviously, and there's also patient outcome motives for reducing lengths of stay, as of course you know. So I don't know if that answers the question, but
Thank you.
thank you.
So my question is to Keara. So I think your work addresses a very important and a timely issue, that is, we do need more policy support for patient engagement, right? Especially given the explosive growth of mobile devices that the patients are using, like exactly what Tom has talked about, right? The health kit, the research kit, such as those devices. So I do have one question about the specific recommendation of adding an RVU for patient engagement. To me, that seems like more like a fee-for-service mode, right? You calculate the efforts that they put, and you pay them based on the efforts. So the whole system now is really transforming to kind of value-based system, right?
Yep.
Where you measure the outcome rather than the effort. So just wonder then whether the value-based system already provides the right incentive for the providers to try to promote patient engagement. So do we still really need the RVU?
Yeah.
Any thought on that?
It's a great question. Thank you so much. So for us, one of the things that's important is that this is really implementable and practical right now. And so, yes, we are absolutely moving towards a VBP model, which does have more correctly aligned incentives from our perspective, but the reality is that there is still a lot of the country that is operating on a fee-for-service model and might be for some time. So although we're moving in that direction, we also wanted to provide practical recommendations for parts of the country and healthcare systems that aren't going to move to VBP, within the next 5 years or something. Does that correctly? Great.
I'll maybe quickly jump in on that one real quick too, and I think from what we see from a HIMSS perspective and the role of technology, I think what was laid out in the Meaningful Use Program with core and menu objectives for providers to adopt technology is probably a really good policy footprint for us to consider as we make the transition to value-based purchasing. Whether it's patient engagement, whether it's the use of other assistive technologies, I think we need to set up an environment for healthcare providers where they feel like they have some sort of say still in how care is being delivered, right? And I think to the extent possible that we could provide them the widest opportunity possible to deploy technology is really going to help us make that transition from fee-for-service to value-based purchasing.
Can I just add one more thing to that really quickly? So from our perspective, you're absolutely right. Like, it's very important to create those incentives so that providers can deliver care the way they want. And so from our perspective, one of the things that we have read extensively in the literature is that providers are interested in having this type of data from patients. So not only do we want to incentivize them to use technology properly to gather that, but we want to reward them for using it in their care to help patients achieve better outcomes. So it's a combination approach from our perspective.
Yeah. Hi. This is a question to all of you, particularly the three in the middle. So I'll wear my technologist hat and ask you the following question. In medical schools, as you know, we have special courses where we actually teach students of medicine how to communicate efficiently and informatively with patients. I have two sons that are doctors, and when they first came with this question, I said, what are you talking about? And they gave me many examples of where this communication is difficult. The question is, when we try to integrate health IT tools between the mobile devices and the hospital, do we have any way of testing the usability and informability of these devices with respect to particular systems diseases between the patient and the doctors and the administrative staff? Because I think still this is an obstacle. In other words, the way that the patient can communicate with the admissions office in an emergency room or other places is not very informative. And if we don't handle that problem, it is my humble opinion, the benefit that is great if we integrate this may not actually materialize. To what extent then application providers test this from both sides, from the patient and from the administrative staff, and finally with the doctor? Because you could, presumably, right, even from the upshot, the beginning of an incident, start programming what resources you need and how you're going to act, what actually you're going to do when the patient arrives at home. Any answers or suggestions would be very welcome.
I don't exclude the other part. We'll stick with the three in the middle.
I think it's a really great question. It's certainly one of these areas where you see how the use of mobile wireless technologies is really sort of the Wild West, right? There's been a couple of efforts historically to provide guidelines or rules of the road, I think, for both developers and users. The challenge that you get into with voluntary guidelines, I think, is that, it becomes very difficult to force folks to adhere to them, right? And it sounds like that's sort of what you're whether it's in medical school, whether it's in the development of the technology, whether it's in how they're applied or they're selected to be deployed in the hospital or healthcare setting. The challenge with them is they're voluntary. Folks aren't going to adhere to them. I think your comment around education of medical students is also really, really on point because we're starting to have this gap in terms of how care is provided, right? I think about the use of mobile devices, and I think I might have said this last year, but that screen, that home screen is very, very important, right? And I think we need to get to a point where we're sharing more information around late-breaking research, around trends. Just think about all the consternation around annual screenings for any given item. So I think, we can't necessarily always dictate a lot of this through policy, because we lose a lot of the innovation and we end up just kind of developing to standards or whatever bar has been set. So it's a big challenge that you just laid out.
Oh, sorry, is it okay? I'm in the middle of the three. Being a recent medical student, I only graduated 3 years ago. In the curriculum, there's a big focus nowadays in the medical school for delivering evidence-based medicine. And the real challenge for mobile health is delivering evidence-based mobile health devices. Not just evidence-based, where it's proven that it does work or it has a clinical effect on patient outcomes, but if it is, in fact, cost-effective. And the problem is, there's only a few FDA-approved mobile health devices that patients can use. And how do you educate these medical students and current physicians to actually advise their patients to use FDA-approved evidence-based mobile health applications? That's the real challenge, and that's what we're all working on. And so from, again, being a young physician who doesn't want to see patients and want to fix the system, sorry. So that's Dr. Zhang's work. That's University of Texas. They have a platform for measuring time and usability for EHRs, but I haven't seen any mobile health push for mobile health usability guidelines from their department. So I might be wrong. So.
And from an MD Anderson perspective, just locally there, I haven't seen it. So that's one of the issues that happens with technology. Is generally there's this rush to go use it up front, but then it never makes it to a very effective use operationally. But you also addressed another good point, and that's communication. So my fear with technologies is that first of all, we don't actually communicate well in the patient-provider interface right now as people without technology. And so in some sense, we're going to try to use the technology as a crutch in there. And there really has to be a balance between those two. So even though we train doctors in medical school around communication, there are individual disciplines that spend their entire career on that interaction, which is psychology, sociology. And so somehow we need to begin integrating those two. The doctors think they do it well. Patients will tell you they thought the doctor did it well when they're in the room with the doctor. When they leave, it's a little bit different story. So.
With that, let's give our panelists another big round of applause.